So once again, good morning, everyone. I will be presenting the first case of pancreatic mass today. So my patient, Madam K, a 45-year-old lady who is currently working as a clerk in a school in Sungai Petani, had presented with the chief complaint of severe abdominal pain for the past 1 week. Now, moving on to her history of presenting illness, my patient was apparently well until 1 week ago when she had started having mild pain in her epigastric region. The pain was constant without any radiation, and she does not attribute the pain to any aggravating or relieving factors. She was unable to characterize the pain. The pain score was at first 4/10, and she also stated that she felt fullness of her abdomen after meals, even if she had consumed a smaller amount of food than normal. 2 days prior to admission, the abdominal pain increased without radiation and pain score was elevated to 7/10. She began vomiting after having her meals, and the vomitus was described as being yellowish and consisted mainly of undigested food without any blood. She also noticed the fullness in the epigastric and para-umbilical areas. As for her past surgical history, the patient was previously diagnosed with acute gallstone pancreatitis after she was admitted to hospital for severe abdominal pain 2 weeks ago. She was treated intensively and her acute condition had resolved. 2 days after the acute condition was resolved, she had undergone a laparoscopic cholecystectomy with no intraoperative complications. As for her past medical history, she does not have any known medical illnesses and she is not on any regular medication other than the analgesics and antibiotics that she was prescribed with after the laparoscopic cholecystectomy procedure was done. As for her family history, there is no family history of similar illnesses and no family history of other chronic illnesses. As for personal history, she is married and she stays with her husband and 3 children who are all in good health. As for her social history, she is a non-smoker, denies consumption of alcohol, and denies any use of recreational illicit drugs or risky sexual behaviors. Her diet and drug history, she takes a normal Malaysian diet and has a preference for seafood, fried chicken, and beef. And she denies having any allergies to food or drugs. As for occupational and marital history, she works as a clerk in a school in Sungai Petani and she's married. So I'll move on to the first set of questions that was presented to me. The first one is highlight the important points in the history. In the history, the important points are first, abdominal pain for the past 1 week that was constant and which had progressed to become severe in the past 2 days. And she also reported postprandial fullness with lower amount of food consumed than normal, vomiting after her food intake, and the vomiting was described as yellowish, fullness in epigastric and para-umbilical area, previous diagnosis of acute gallstone pancreatitis 2 weeks prior to her current admission, with a laparoscopic cholecystectomy procedure done, and her diet preference for seafood, fried chicken, and beef. Moving on to the second question, what is the clinical problem as revealed in the history? The patient is currently having the signs of acute gastric outlet obstruction, which include abdominal pain, reports of fullness in the epigastrium region, and also vomiting undigested food particles. There could also be a possible large pseudocyst of the pancreas causing the gastric outlet obstruction. So why I say so is that because of a recent history of acute gallstone pancreatitis, presence of feeling of fullness postprandially, yellowish vomitus after her food consumption, and the progressive abdominal pain in the epigastric region. And this could also be due to a probable insufficient drainage of pancreatic fluid during the laparoscopic cholecystectomy procedure, which could have caused the formation of the pseudocyst. Okay, So moving on to the general examination. On general examination, my patient was conscious, alert, and well-oriented to her time, place, and person. She was lying supine on the examination bed with her head supported with one pillow, and the patient appeared to be in pain. However, she was not in any respiratory distress. She was of normal build for her age, and there is some evidence of a recent weight loss. She was mildly dehydrated with adequate ventilation, and there was no conjunctival pallor or scleral icterus that could be seen, and no cervical lymphadenopathy was found. Her vital signs were as follows. Her blood pressure was at 160 per 86 millimeter mercury. Her pulse was 100 beats per minute with good volume and regular character. Her temperature was 38 degrees Celsius, and her respiratory rate was 24 breaths per minute. Okay, moving on to the systemic examination that was done. On inspection, the patient's abdomen was distended on the upper abdomen, mainly in the epigastrium area. The patient's umbilicus was centrally located and inverted. There were no striae, no visible pulsations, no visible peristalsis, and no engorged superficial veins were seen on the patient's abdomen. So later there will be a photo of the patient's abdomen. As for palpation, there was no guarding of abdomen on palpation. Mass could be palpated. Sorry, doctor. There was guarding of abdomen on palpation. And a mass could be palpated in the lower epigastric region, measuring about 12 centimeter by 8 centimeter, which was partially mobile and tender to the palpation. No skin changes or pulsations were seen over the mass, and no bruit was heard over the mass. The mass was more warmer than the surrounding body temperature. The mass was globular and smooth with well-defined margins. Other than that, no hepatomegaly or splenomegaly was able to be palpated. Moving on to the percussion, the mass was dull on percussion, and all the other quadrants of the abdomen were normally resonant. And moving on to the auscultation, bowel sounds were found to be sluggish. So this is the photo that was provided of the patient's abdomen. So the next set of questions on examination, the first question is identify the main signs in the patient. So the main signs in this patient were the presence of a tender palpable mass measuring 12 by 8 centimeters in the epigastric region. The next sign is the percussion of the mass was dull, and the last main sign that in this patient is the presence of sluggish bowel sounds, which might indicate bowel or gastric outlet obstruction. The second question is, the above is a picture of the patient in the supine position. Describe the findings on inspection. So on inspection of the patient's abdomen in the photo previously showed a distended upper abdomen in the epigastric region. Upper abdomen has a prominent lumpy kind of appearance with no visible distended veins or skin changes seen. And the umbilicus was centrally located and inverted. No scars were visible, and there was no visible pulsations or peristalsis seen. And there was no skin discoloration of skin over the flanks and umbilical region. So coming to the last question, what is the most likely diagnosis in this case? I would say gastric outlet obstruction secondary to the formation of a large pancreatic pseudocyst. My differential diagnosis would include peptic ulcer disease and also carcinoma head of pancreas. Doctor, can I move on to investigations?
I think you go back to show me the picture of the patient.
Okay.
Okay. Then I want you to describe. I know you already described. So how will you describe this case? Let's say if this is the patient, because this is not the patient. So assuming this is the patient, how will you describe the mass now?
Okay. On inspection of the abdomen, doctor, the abdomen is distended in the upper half of the abdomen, mainly in the epigastric region. There is appearance of an irregular surface of the distension, and there are no scars or any visible engorged veins in the area.
Okay, and this mass, they say, is partially mobile and tender. There's some guiding around. Okay. All right. So these are the features. Later we'll discuss that. Okay. Now we go back to your investigation now. So far from your history and physical examination, your diagnosis is pseudo-cyst of the pancreas with obstruction, gastric obstruction. All right.
Yes, doctor.
What are the differential diagnoses?
The differential diagnosis that I'd like to offer is peptic ulcer disease and also carcinoma head of pancreas.
Okay. Why peptic ulcer disease? Does it fit into your patient's problem?
Peptic ulcer disease because she's having severe abdominal pain. She is also she's actually also having vomiting postprandially, doctor. So,
okay. So why do you get mass there in peptic ulcer? Do you get a big mass like that in peptic ulcer?
no, doctor.
So what do you think? Can get, in what conditions of the peptic ulcer can you get a mass like that?
Not sure, doctor.
Not sure. Anybody want to offer any suggestion? Irene, you want to offer some suggestion?
No.
No suggestion. Okay, this one can be, sometimes it is a perforated ulcer. See, this patient came in with a very severe pain, is it? So it can be a perforated ulcer. So once it's perforated, it can form abscess there. Or if it is a chronic ulcer, it can cause pyloric obstruction, gastric outlet obstruction. And that can cause a gastric outlet obstruction syndrome. So what you're seeing there is this big distended stomach. Okay, peptic ulcer is possible, but normal peptic ulcer cannot. It must be either is outlet obstruction or perforated. Okay. What other diagnoses that you offer?
My other diagnosis would be carcinoma head of pancreas, doctor.
Okay, it's possible. What is the points against this diagnosis of carcinoma of pancreas?
The points against the diagnosis of carcinoma head of pancreas in this patient is, first of all, her age group. She is just 45 years old, whereas CA head of pancreas is usually present in the age group above 65.
Okay, good.
Carcinoma head of pancreas also occurs mostly in chronic alcoholics, whereas she does not consume any alcohol, or she denies consuming any alcohol.
Okay.
And that's all of the points against.
What about the onset of the history and all that?
The onset of the history is acute, doctor, whereas in carcinoma head of pancreas, it will be long-standing or chronic.
What other symptoms can you get? It is a long-standing. So what other symptoms can you get in carcinoma of pancreas, which is not there in this patient?
You can get jaundice.
Okay. Good.
Jaundice.
If it is a cancer, what are the other features you can get? General features.
Loss of drastic loss of weight.
Yes, yes, loss of weight. Okay. Then it becomes very emaciated. Okay, loss of weight, tiredness, emaciated, it may be pale. Okay, these are the features of a malignant features. These are the things. Okay, any other diagnosis they can offer which is relevant to this patient?
Not sure, doctor.
Okay, anybody can offer another diagnosis. This is the patient with acute pancreatitis. So what other pseudocyst is it related to the acute pancreatitis?
It can be a complication of acute
Yes, it's a
pancreatitis.
complication. What other complication of acute pancreatitis can present as a mass, epigastric mass?
Doctor, maybe possible is pancreatic abscess.
Yes, good. Pancreatic abscess. First necrosis first. Okay, can be massive pancreatic necrosis. So it forms a mass. Later I'll show you the CT scan afterwards. And you fix a big mass there. So the mass can be either a cyst. Now the problem is pancreatitis followed by epigastric mass and vomiting. Then there's a mass that's developed. Patient is having fever. Patient is having tachycardia. Okay, Arvind. So these are the important things. So it can your first choice should be related to acute pancreatitis. Okay, and this is already 2 weeks now, so you can be a cyst. I agree with you. It can be necrosis, massive necrosis, and that means a necrotic mass. Or if it is infected, it can become a pancreatic abscess. Okay, so these are important differential diagnosis. Always when you come to a diagnosis, you try to tie up with one diagnosis to explain everything. Then your differential. Differential usually you see unlikely, I see the peptic ulcer doesn't fit 100% into your system, into your patient. The cancer also just now we discussed, it doesn't fit 100% into your patient's condition. All right. So it's a very so those are differential. Okay. So understand. So I would put the diagnosis as post you in your history. I think what was the thing that you did well, you achieved complaint, everything very good, but you should have highlighted the acute pancreatitis into the present HOPI. Because this is directly related, you're trying to say, you cannot say it's past history. Past history means sometimes gone already. So now it is only 2 weeks, so it cannot be past history. So you should, in the history of present illness, you must mention patient is a known case of acute gallstone pancreatitis for which a lab poly was done 2 weeks ago. Now she comes back with severe pain again for the last 1 week, associated with epigastric pain, fullness, and vomiting. Okay, understand?
Yes,
so
doctor.
that was the only thing which I feel. I mean, yours is okay. I think it should be no problem. But you haven't emphasized the importance of acute pancreatitis because your diagnosis is going to be related to your acute pancreatitis. If she had the acute pancreatitis, say 3 months ago, and then now she comes with a mass, then you can say like a past history. But now this is directly related. That means patient went home, after a few days, maybe she developed this pain again. Okay, so that is the important, that's the thing I want to comment. Okay, your diagnosis of gastric outlet obstruction is very good. In fact, I also never thought of it. And now she comes with acute gastric outlet obstruction associated with tenderness and fever. So if the tenderness and fever now, it can also be pancreatic abscess. Okay, necrosis usually don't have fever. Now got fever, and that's so that means she's going to septicemic or some sort of sepsis. So pancreatic abscess now. Or the pseudocyst really does not cause any fever. But if the pseudocyst gets infected, again they can have fever. So these are the salient features you must add in now. Say gastric outlet obstruction due to a pseudocyst of the pancreas from acute pancreatitis. Possibly now it has got infected or there is an abscess form. This is the complete picture of the patient. Okay? All right. Now when you examine the patient, the features, What does this dullness on percussion of the lump, what does that, does it signify?
It signifies that the lump may be cystic in nature.
Okay, good. Or
The lump is solid.
yes, good. What are the what's the other thing which excludes if it is dull? It can be either cystic or solid. Okay, so it excludes. I told you gastric outlet obstruction with distended stomach. So it excludes a distended, just a primarily distended stomach as the cause, like peptic ulcer. Because if it's a distended stomach, when you percuss, what you get?
Normally it will be resonant, doctor.
Yes, resonant. Okay, it should be resonant. So that's very important in this patient. When you get a lump in the epigastric region, number one, you must look for percussion. That is a simple test which can tell you it is not a stomach. Of course, it is between a fluid and a solid. Solid is cancer or abscess. Fluid means it must be a cyst, which is a pseudocyst. Okay, so on a clinical examination or simple examination like that, percussion can narrow down your diagnosis to 1 or 2. Okay.
Okay, doctor.
That was one. And then the partially mobile. If it is a gastric, it will be mobile how?
If it was gastric, it will be I'm sorry, doctor, I don't understand your question.
Okay, let's say if it is it says partially mobile. Normally a stomach in the epigastric region, if it is a stomach, it should be mobile in 2 directions, up and down and right to left. Okay, why is in this case it's not mobile like that? It's partially, only a little bit slightly mobile. So what does that narrow down your the organ from which the lump is from?
In suspicion of pancreatic pseudocyst, doctor,
Mm-hmm.
the lump cannot move freely upwards due to the surface of the duodenum and
Yes.
the gastric outlet preventing it from moving up.
So it cannot move up and down freely. It can move sideways slightly because it's a retroperitoneal organ. If it is stomach, it can move freely in all directions. Again, it comes down now. It is unlikely to be a stomach. It's more likely to be maybe a pancreatic mass. Okay, that's the other one. Okay, otherwise quite good. You can go on to your investigation.
Okay, so as for my investigations, I would like to conduct routine investigations first of all, such as full blood count, liver and renal function test, and also a chest X-ray done.
Okay.
Next, for more specific investigations, I will go for an abdominal ultrasound and also an endoscopic ultrasound to help me determine whether the mass is cystic or not. And to be more specific, I will go for aspiration, ultrasound guided aspiration of the cystic fluid if there was a fluid found on the endoscopic ultrasound, which then I will send for cytology. And if there is suspicion of a carcinoma of head or pancreas, I would also like to send for measurement of carcinoembryogenic antigen levels, CEA levels. And I would also like to check the serum amylase levels and also the pancreatic fluid amylase levels. The final one I would like to do is endoscopic retrograde cholangiopancreatography, ERCP, which will be helpful for me in planning a drainage strategy of the pseudocyst.
Okay. That's all, is it?
Yes, doctor.
Any other investigation? No, okay. First, so which is the order? Blood test and urine, straight away you do the patient. Okay, you mentioned. In the imaging investigations, what will be your order of your investigation in this patient?
First of all, I will start off with the abdominal ultrasound and endoscopic ultrasound first, doctor.
Okay.
Then I will move on to a non-contrast enhanced CT scan.
Okay.
And then finally, I'll go for endoscopic retrograde ARCP, doctor.
Okay. So your investigation will be first, I think you mentioned just now, you should say X-ray. You said yesterday you will do a chest X-ray. Why would you want to do a chest X-ray?
To check for any secondaries to the lung, any pleural effusion.
Think of your diagnosis, huh? Pleural effusion or secondaries. Pleural effusion. Okay. So acute pancreatitis, they can get pleural effusion. Okay. Okay. Good. Anything else? Or whether this patient has just had an operation, so she can come back with pneumonia also. So that's why very important in this patient to do a chest X-ray. So that will be your first. Always start from least invasive, least radiation to more invasive, more radiation. So first of all will be your chest X-ray. And if one, you can do abdominal X-ray also in this patient. Huh? Then after that, you go for ultrasound. Abdominal ultrasound first. And then decide whether you want to do an endoscopic ultrasound. That because it's not available in many hospitals. Huh? So of course, abdominal ultrasound is a must, which is available everywhere. And third, CT scan. I agree with you. Okay, now you say you want to do a ERCP. When will you want to do a ERCP patient?
I'll do an ERCP on this patient once the nature of the mass is confirmed by abdominal ultrasound or endoscopic ultrasound. Mm-hmm. So if it is found to be cystic, I will then do a ERCP to find out how to drain the fluid from the pseudocyst, doctor.
Okay. What are the complications of ERCP?
Complications of ERCP.
Which is a very real threat or danger in this patient doing it for ERCP.
Is it recurrent pancreatitis, doctor?
He can cause another acute attack of pancreatitis. Very, very important. And if he gets another attack of acute pancreatitis, he can be fatal. So I will try not to do ERCP unless it's really necessary. Okay. So okay. ERCP we won't do. This X-ray, ultrasound, and CT scan. These are the three. ERCP we will not do just to see whether it's how to drain. That can come later. Because in the process, if you trigger another acute pancreatitis, patient can die. Right?
Okay, doctor.
Okay, now go to your management.
So as for the treatment of this patient, first of all, to relieve her symptoms of the gastric outlet obstruction, the patient can be provided with histamine 2 blockers to reduce the gastric acid secretion for relief. However, we need to monitor the patient for 48 to 72 hours upon starting the treatment with the histamine 2 blockers. Next, the pseudocyst is a condition in which it will resolve, but usually resolve spontaneously. We can treat. Meanwhile, we can treat this patient by providing adequate analgesia and antiemetic medication, and we monitor for the development of signs of ruptured pseudocyst, which include signs such as blood in vomiters, decrease or loss of consciousness, and weak or rapid pulse rate. And we have to follow up this patient in 6 weeks' time. So that is the medical approach. As for the surgical approach, we need to conduct drainage of the pseudocyst. So this can be done in 3 ways, which is percutaneous drainage, endoscopic drainage, and also open surgical drainage. So usually a double pigtail drain can be placed with one end in the cyst cavity and the other end in the gastric lumen to drain the pseudocyst. And occasionally, if ERCP is not contraindicated, it can be used to facilitate the placement of a stent across the ampulla, which may help in draining the pseudocyst. And the surgical drainage involves internally draining the cyst into gastric or jejunal lumen. And this surgical drainage procedure is known as a operative cyst gastrostomy, and it can be done laparoscopically or endoscopically as well.
Okay.
Okay, this is a photo of the cyst gastrostomy, doctor.
Okay, I'll show you some pictures and also a short video on how this is done. We're going to do that. Okay, management, these are the things. As far as you are concerned, final year, important thing is how will you manage the patient? Okay, that means management means always first confirm diagnosis. That we already done investigation. Okay, your diagnosis is acute pancreatitis with pseudocyst of the pancreas. Okay, so in this patient, you want to do all the investigations to confirm the test you've done. So you want to treat, first of all, the patient is in pain and in dehydrated. So you got to resuscitate the patient. Okay, the standard things are IV fluid, analgesics, antibiotics, and if you need to put tube in this patient, the patient is distended stomach. So you put a nasogastric tube to aspirate the stomach. That is very fast relief. You can give medication, it won't help so fast. All right, histamine and all that will take long time, right? So nasogastric tube. Okay, and then the other one is okay. Then your drainage can be percutaneous or endoscopic or surgery, which we'll discuss in later. I think this one I won't go into the details of it. So I'll just tell you. So you must just know the principle of it. Okay, any question? Before I show you some, like, okay, I think Arravinnath, I think is quite okay. The clinical question I'll ask you at the end of after showing you the slides and all that. Okay, anybody want to ask any question? You got anything else to show, Arvind?
No, doctor. That's all.
Okay, can take out this thing. I'll share my screen. Okay, I'll run through very fast because we won't have time. Okay, this one, I think I already described this to you. Okay, this is your lateral view. So you must be very, very important. So this is a case of pseudocyst of the pancreas, which is a common complication of pancreatitis, acute pancreatitis. Here, this is the patient has got distended stomach. You can describe from the front and from the back. Same thing, is a diffuse enlargement, okay, slightly lobulated, some in this, and sometimes it is smooth. So dullness and percussion, I told you just now, these are all very important things that you must look for in these patients. And this patient looks like a bit jaundice, okay, but our patient is not jaundice. So these are the things you'll be asked to look at, to examine the patient, to inspection, okay. We can't give you the, what we call, exact patient, so we can at least give you you can do the inspection, all right. Just push up, okay. Now, okay, this is the abdomen, this is the other patient. You must know how to do it. Okay, the other one, this is a abdominal mass, very smooth. You can see the surface very smooth. Okay, very smooth, not lobulated, no skin changes. And this is viewing from the lateral side. Again, epigastric mass moved to the left side of the abdomen is either stomach, spleen, or pancreas. Okay, these are the three things. In surgery, it is usually stomach and pancreas. Spleen will be an enlarged, large spleen also can cause this. This is another lump of an abdominal patient. Okay, abdominal lump in the upper part here. Again, it's smooth, rounded. Again, you have to think of the spleen, you have to think of the stomach and the pancreas. All right. Okay, so just Arvind said these are the symptoms that we came across. Okay, we got summarized a 45-year-old woman, acute gallstone pancreatitis 2 weeks ago, and then lab chole done. Now she comes back of epigastric pain, vomiting, and unrest. Okay, Then you also get a mass in the epigastric region, which is smooth in nature, and she has got fever and dehydration and tachycardia. So based on these features, okay, Arvind made the diagnosis of acute pancreatitis, blood coli, recurrent fever and vomiting. This is the problem with epigastric mass. So acidosis of the pancreas will be the diagnosis. Okay, with pancreatic necrosis, abscess. In fact, he has got other things also. Okay, it says CA pancreas and also peptic ulcer with gastric outlet obstruction. So these are the diagnoses that you can offer for this patient. Okay. Now, based on this examination, okay, these are the results that you said you will do. Okay, blood, all these I think mentioned already. Okay, you also said you will do a urine amylase also. Also is very important. The fluid also can send for amylase. Okay. Okay, Arvind, what can you see of this? This is ultrasound of the patient. What can you see? Just tell me a few words what you find in this ultrasound.
There is a hypoechoic. There's a hypoechoic. Region can be seen, doctor.
Okay, hypoechoic region.
With the appearance of a slightly thickened wall.
Okay, slightly thickened wall and some hyperechoic shadows within it. Okay, this is different view. This showing it causes obstruction, compression of the pancreatic duct and the kidney. All right, we don't bother about this to only this. So it shows a large cystic mass in the ultrasound of the. This is ultrasound at the upper abdomen. So this is a pancreas. Probably in this patient is a pancreatic cyst. All right, large pancreatic cyst. Normally pseudocysts, they got multiple septa within it. Okay, so this is the thing. Okay, then you said you will do a CT scan. So what is the CT scan? What do you see? Ravi?
There is an I'm not sure how to describe it, doctor.
You must say something wrong also, Namai. Don't tell the examiner, don't tell the examiner I don't know how to describe.
Okay, there is a large hyper dense large hyper dense
lesion
of
mass in the left side of the abdomen. In fact, it occupies almost the whole of the left side. Here it compresses the stomach here. The stomach shadow is so small here. Then at the back, posteriorly, it compresses on the on the kidney. Okay, left kidney. So it's a large hyperdense circular lesion, which is looks like a cyst. All right, turbid fluid within it. It's not abscess yet. Maybe it's turbid fluid. That's why it's not clear. With a well-defined margin. So what are the organs that are found in this area? Stomach, kidney,
kidney, and
this is the pancreas. Can you see head of the pancreas? So the cyst coming from the pancreatic, from the pancreas. All right. So these are the few features you must mention. Large mass, cystic, well encapsulated, anteriorly compressing on the stomach and posteriorly the kidney. Okay, and then it seems to be originating from the head of the pancreas. Okay, Arvind?
Okay, doctor.
Okay, so this is your diagnosis now. Pseudocyst pancreas, post-gallstone pancreatitis. This one just to show you all. This is the pseudocyst. This is another pseudocyst of the patient. Not this one is the television. So usually it's well encapsulated, originating from the pancreas here. Okay, here. This is another. This shows extensive necrosis. Extensive necrosis. So this also can be felt as a mass per abdomen. Okay, necrosis, abscess, well defined. Inside, you see, is a slightly less dense compared to the liver, and and the soft tissues are slightly less semi-liquid. Okay, now we come to the management. I told you, management, you come initial treatment. These are the things. Okay, always generally you confirm diagnosis and resuscitation and medical treatment. This will be your initial treatment for all surgical cases. All right. So this we have already done. Fluids, always few things only. IV fluid, electrolytes, close monitoring, insertion of a nasogastric tube, and whether you want to put a catheter. So all these, I think, in this patient, I will do. I will put all these things there, and then to monitor the patient. And then the definitive treatment. What's the definitive treatment? This is antibiotics in this patient. And if the amylase is high, that means the patient is still having some mild pancreatitis, you may want to give somatostatin. That doesn't matter. Mainly is fluids and antibiotics and painkillers. Surgical is you have to drain the cyst. How will you drain? It's known as a cyst gastrostomy. Okay, which can be done endoscopically, laparoscopically, or open surgery. All right, so this will be the outline of management. When they ask you the last part, outline of management, these are the things that you must include. Okay, in surgery, always confirm diagnosis, resuscitation, definite supportive treatment, that is eye fluids and all that, and medical treatment, followed by surgery. Surgery, again, nowadays can be endoscopic, laparoscopic, or open surgery. Okay, any question? Okay, I'll just tell you what is the cyst gastrostomy. You see, here is a cyst here. Okay, posterior to the stomach. Okay, this is the pancreas. This yellow thing is the pancreas. So this is a cyst here. So what you want to do is you want to drain the cyst into the stomach, lumen of the stomach. Contains fluid, I want to drain. So you create a fistula between the cyst and the stomach, posterior wall of the stomach. And that here, and that is known as the cyst gastrostomy. All right. So it's the anterior wall of the stomach. You open up the anterior wall. You go to the posterior wall. Open up, make an incision here. Open up the posterior wall, and then you create a fistula like this. Okay, this gastrostomy. Then you drain out all this fluid. Suck out all the fluid from here. Drain out the pus and abscess or necrotic tissue, everything you scrape it out, and then you put a NG tube, drain the thing here. Okay, and this cyst will then close by itself. When there's no the pressure here becomes negative, this will close by itself. So spontaneous closure of the fistula. Okay, so this is how it looks like after the cystostomy. This is the surgical open cystostomy I'm describing to explain to you. Okay, this one we already still give a short clinical summary of the patient's illness. Okay, just now we already given this laparoscopic cholecystectomy for acute pancreatitis 2 weeks ago. And now she come back with this problem. In examination, there's a large mass. So this is the summary, okay, before you come to your diagnosis. What is the present diagnosis? We already discussed this in detail. CA pancreas. The other one is stomach. Anything in the stomach also you must know. Pancreatic necrosis, pseudocyst of the pancreas. Investigations. This one we already gone through and outline the treatment from now on. These are the things we already done this. Okay. Confirmed diagnosis, initial treatment, resuscitation, then surgery. Cyst gastrostomy. And then, what are the complications of pancreatitis? Arravinnath, acute pancreatitis.
Sorry, doctor?
What are the complications of acute pancreatitis?
Formation of pseudocyst, pancreatic abscess,
massive necrosis.
and also,
so you can classify in the local and systemic. Local will be necrosis, abscess, pseudocyst. Systemic will be multi-organ function failure, multi-organ failure, can be recurrence, can be chronic pancreatitis. All right, so you just classify them. Huh? Maybe I'll send you all these slides later to IB, so you can go through. All right. Okay, shall we do the? Okay, this is the question I wanted to ask you, Arvind. You are the doctor at the ED at the time the patient comes in. So, what will be your initial treatment in the ED? Like, will be when you admit the patient? Already gone through. You just summarize it.
In the emergency department, first I would like to provide the patient, resuscitate the patient with IV fluids, and start her on analgesia, provide analgesia. Next, I would like to go for an abdominal ultrasound, since it's a non-invasive and inexpensive technique. And I will also I'm not sure, doctor, how.
Painkiller, you mentioned, antibiotics.
Yeah, analgesia and antibiotics.
There's a big mass in the abdomen, there's vomiting. You want to put a nasogastric tube. Patient is dehydrated, so you want to monitor the urine output, so you want to put a
urinary catheter.
Or CVD, they call it, continuous urinary catheter. These are the few things. And general, every case, this one, they ask you to mention these 5 things. Vomit out, I think you will be right. Okay, every urgent case must be done like that. Okay, so first, then you confirm diagnosis. First, you resuscitate with all those things. Monitoring is the one. NG tube, nasogastric tube, plus urinary catheter. Then confirm. Investigations, I think you already mentioned this. Okay, then you can be asked to explain. You are going to take consent for the patient for the operation. Your surgeon has decided we want to do a laparoscopic cyst gastrostomy. Okay, how will you explain this to the patient? Just in outline, principle.
For this patient, first of all, I will explain the principles of the procedure. I will explain what is the benefits of this procedure, and I will also inform the patient of these possible adverse side effects or consequences, negative consequences of this procedure. And yeah, that is how I'd like to get a consent from this procedure, from this patient, doctor.
Okay, you tell everything. The patient, like most of our our patients, our Asian patients, you will say, doctor, saya tak mau buat. Bolehkah saya tak mau buat?
I will advise the patient to continue with the procedure because pseudocysts may rupture or get infected, and it could be life-threatening to the patient.
That's good. So you have to tell them the complications if you don't do. Because what size cyst you can wait and see. What's the size of the cyst that you can wait?
The cyst can be less than 6 centimeter and not rapidly growing in size.
6 is quite big, you know. Where you saw the 6? You guess or you saw?
I remember seeing it on a website, doctor. Either website or Bailey and Love. I'm not sure.
Some books give you, nowadays most books give you 3 cm, but generally the accepted one is 5 centimeters. Okay, if you say 3 or some, nowadays because it can easy to drain, so try to drain the cyst much smaller. So 3 to 5 centimeters, within 5 centimeters maybe you can wait. Patient says saya tak mau buat, you say okay, kita tengok macam mana. Lepas 1 minggu kita buat scan balik. If the cyst does not grow, then maybe if it goes shrinks, then better still. All right. So in the explanation, these are things you have to explain the procedure of GA. Patient is done under general anesthesia. Laparoscopy involves making of holes in your abdomen, 4 or 5, usually it's 3 or 4 holes. What are they called? Then they open the stomach, open the anterior wall, posterior wall, which I showed in the flow chart just now. Then open the posterior wall, go into the cyst, drain the fluid. Then you put an NG tube, close up the wound. Then wait for the cyst to close by itself. Okay, this is, I give you the tips for you. You have to, then you see the video, I think you should be able to explain. Okay. Okay, Irene, you have to do some listing now.
Yeah, launch the poll, Doctor.
Yeah, launch the poll. Okay, this is
Can you see, Doctor?
3 questions. I say we supposed to have shown this at the beginning. We forgot. We just read the question and then everybody answer. Got 3 polls for this case. The causes of pancreatic pseudocyst include the following: except, give you the 1 minute altogether, another 30 seconds. Come faster. Okay, okay, can end the poll. We can end the poll, then share the result. Okay, so I think all of you got right. Gallstone pancreatitis is the most common cause. Alcoholic is the second common cause of acute pancreatitis, and chronic pancreatitis also can cause a pseudocyst. Okay, but it is less common than the first two. So adenocarcinoma pancreas, not a cause. Okay, stop sharing, and now we go to the next question. The poll again. Question number 2: most useful imaging method of pancreatic cirrhosis. Start. Okay, I think we can end the poll and share. Okay, right? CT scan. All of them can be done for cirrhosis of the pancreas. But the most important is CT scan. If they ask you 2, then I would say ultrasound. But I think the most useful is CT scan. Even between ultrasound and CT scan is more useful. From the images which I showed you just now, you should be impressed that the CT scan is the most important investigation. All right. If anybody got any question, can interrupt. Okay, go to the next question, Ivy. Last question.
Sorry, I let this
On again.
we launched the third call.
Okay, launch again.
Sorry, I disconnected just now. Do I launch a third call?
Yeah, can launch the third one. Okay, this one is surgical treatment of pseudocyst of the pancreas. Okay, can start. Okay, 10 seconds more. Okay, all answered. Can share the result. Okay, I think there are two answers to this question. Endoscopic and laparoscopic cyst gastrostomy. There are two answers. Either both also can be done. So I think most commonly done is laparoscopic. Okay, there are three types. Open, laparoscopic, endoscopic. Endoscopic is not available in many places. In places where you can do endoscopic ultrasound, then they do this procedure as well. So most places is either open or laparoscopic. Nowadays, it's laparoscopic everywhere. Okay. So any question? I think we can stop this. Stop sharing. Okay, any question or not before I show you the short video, 5 minutes.
Doctor, the choice for the surgery, either endoscopic or laparoscopic or open, is based on the equipment available, is it? Or based
Equipment
on the
available,
condition?
yeah. Mainly nowadays they tend to do a laparoscopy because it's less invasive. But if it's not available, then you do open. So since I think in a lot of hospitals they still do open. Like I come from the old school where I'm used to the open method. Actually, it's a very simple procedure. But nowadays people want minimally invasive, then you have to go for laparoscopy. Open surgery takes maybe less than an hour. Okay, about 45 minutes you can finish. So in a small patient. So depends on the surgeon's experience, what he can do. If he can do laparoscopy, nowadays a lot of the younger surgeons can do laparoscopy. So what we do is, then they do that. So the recovery is faster, patient, less complications. But it takes a bit longer time. What I'm going to show you is laparoscopic procedure. Okay. Can you all see?
Yeah, yes, doctor.
Can,
This is an abdominal CT of a man 4 weeks after an attack of acute pancreatitis. It shows a large cyst behind the stomach, as shown by the yellow lines. The laparoscopic cyst gastrostomy was planned and it was undertaken.
The stomach is seen pushed anteriorly by a retrogastric pseudocyst of the pancreas. An opening is made in the anterior wall of the stomach over the area of the pyloric antrum where the bulge is maximum. The incision is closer to the greater curvature than the lesser curvature. One can see that the posterior mucosal folds of the gastric wall have been flattened out. The cyst cavity is aspirated to confirm the nature of the contents.
Aspiration reveals fluid which is thin and dirty.
After the nature has been confirmed, the posterior wall of the stomach along with the anterior wall of the cyst are opened up and the contents of the cyst cavity flow out. The contents are aspirated and one can see about 1.5 centimeter opening from the posterior wall of the stomach into the cyst cavity. An echelon 60 stapler with a green cartridge is used to enlarge this opening from the posterior wall of the stomach into the cyst cavity. Care should be taken that the stapler does not pick up the anterior wall of the stomach. The inside of the cyst is inspected, any remaining fluid is aspirated, and the necrotic material is seen. All the loose necrotic material in the cyst cavity is removed. Hemostasis is checked. The nasogastric tube is positioned into the cyst cavity. After confirming hemostasis, the opening in the anterior wall of the stomach is closed with a single layer of running sutures using a 20 vicryl. One can see that the cyst has collapsed and now the anterior wall of the stomach is not anymore bulging anterior to the liver. The bites are generally taken extramucosal, taking the remaining full thickness of the stomach wall. The suture line is checked for a good approximation, and the suture is continued towards the medial end. After tying the knots on the medial end, the suture line is again checked for hemostasis and good approximation. The patients will generally be started liquid diet on the next day if the rice tube aspiration is less.
So these are the advantages of laparoscopic: less pain, less roof top incision required for open symptoms, and less pulmonary complication, gas or anesthetic complication. Okay, that's all for this first part of it. Any on your video for a while? Just to sum up. Okay, Alvin, any question or any comments?
No, doctor.
So final year, you have to ask the other part, which I have no time to go through, is post-operative problems. What you will do in the post-operative mistakes. So that is another important thing that you must do. Post-op complications. Again, few things is pre-operative, post-operative. Then what are the complications of the surgery? Okay. So any questions? So this is the cyst gastrostomy. Somebody asked me, how do you decide which method to use? It's basically on the surgeon and the place where you are capable. The surgeon, which is he comfortable to do. Say like I've been doing open method for so many years. Okay, open cyst gastrostomy. I've done quite a number. So now suddenly this patient comes, and this patient is a high-risk patient. Okay, acute pancreatitis, and then she has got in fact evidence of sepsis and all that. So I don't want to waste time on doing something which I'm not so familiar. So I go and do a new procedure. I'll be taking a long time. So I'll go do something which is I'm so comfortable. I can go in straight, do and come out faster the better. All right. So it depends on the surgeon and also on the facilities available. Okay. Ideally, the least invasive is the best, but it's not always available in many cases. Okay. Any question?
Doctor, I have a question.
Yeah.
One of the complications for cyst gastrostomy is pancreatic abscess, doctor. Is it worth taking the risk to do that procedure for in case pancreatic abscess can occur later on?
Now, once like in this case, when you open the cyst, you remove all the necrotic tissue. Okay, and all the pus, if it is there, we suck out everything, and then we usually flush it. Use some saline, flush everything. Then what you do is, then most of the time the chance of abscess is very much less. Okay, so you have to clear everything first, and then also you see the cavity is open into the stomach, and you put a nasogastric tube. So whatever keeps draining, in fact, for a few days it will drain. So you aspirate in the stomach, nasogastric tube, and try to get it out. Okay.
Okay, thank you, doctor.
But if you don't drain it out, then the chances of abscess is much higher because it's a closed compartment. All right.